Hello. Hello.
Yes,
Are you
doctor.
guys able to hear me properly?
Yes.
Hello. Am I audible?
Yes, doctor,
Ye-
we can hear you.
Yes, we can hear you.
Yes, yes.
Okay. So can anyone speak because I'm just the voice of you guys it's really low voice. Can you just please anyone who can speak loudly? Hello. Am I audible?
Yes, yes, hello.
Okay, that's great. Okay, okay, that's great. So today we'll be starting our session on MSK, right? And first of all, we are going to study the slides from boards and beyonds, right? So we are going to be referring towards slides of boards and beyonds. And after that, we'll be going through first aid, right? Because everything here is written really in an organized way, right? So we are going to be starting from here and then we'll be moving to our first aid in our boot camp session. Okay. So let's start our session today. Okay. Let me just. Okay. So I have again switched to my pencil, right? Mhm. So the first topic which we'll be discussing today is knee. Okay. Okay. So you should remember that knee is basically made up of four bones. You can just imagine which bones knee are made up of. Knee is made up of. So you have this big bone, femur. We know that. We have our tibia and we have our fibula. And don't forget small bone which is patella, right? Patella is really important bone, right? Like as we know that it's really a small bone, but the importance is really great because we are going to discuss it in our future lectures. If we have fracture to the patella, what would happen? Before getting into that, you
Doctor,
think
voice is
one
breaking.
thing in your mind. Hello,
Yes,
Your
Dr.
voice is
Ahmed,
breaking.
your voice is breaking.
my voice is breaking. Okay, okay, just give me a
Yes,
second,
yes.
please. Okay. Hello. Hello.
Yes, sir.
yes,
Now it's
Okay, now is it fine?
yes.
okay. Yes, sir.
Okay. Okay, that's great.
Yes, doc. Clear them.
Okay. So we were discussing about knee. We discussed that knee is basically made up of four main bones, right? The big bone is your femur. Then you have your tibia, your fibula. We will be discussing that in detail, and a small bone called patella. So I was discussing that patella, even being like so small bone, it's really important. And why is it important? You guys can see here this big muscle, right? This big muscles of your anterior thigh, which we will be discussing in our future lectures. But let me here just give you the concept of patella. Why is it so important? So you guys can see it here that the common tendon of these muscles are moving upon the patella, and they are inserted here. This structure is your tibial tuberosity. It's really important. We'll be discussing a pathology and I'll be telling you the significance of this tibial tuberosity, right? So you guys can see the only communication of this big muscles with your lower leg here is this patellar bone. You can see, it passes on the top of patella and it just get inserted into tibial tuberosity. So even if this small bone is fractured, so you'll be having a lot of problem. And what's the problem you guys are going to see? The problem is that now you cannot redistribute your upper body weight You cannot redistribute your upper body weight through, on your leg, right? So if this communication is break, so you're going to break this entire communication. So this patella bone is really small, but it have a lot of significance, right? Then we have different ligaments. Can anyone just tell me what are ligaments? Hello. What's the difference between tendon and ligaments?
Tendon connects bone to
bone, this connect
muscle.
yes, and the ligaments is the continuation of the muscles that connect one end with
Okay.
the bone.
Muscles to bone,
Yes,
tendons, bone
bone to bone.
to bone. Perfect. Right? So we have four ligaments which we'll be discussing here, right? What are those ligaments? Anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament, and lateral collateral ligament. Let me just give you an overview of these ligaments, right? The word cruciate basically means cross. Whenever I'm just writing a cross, it's basically a cruciate, right? Cross. It means that anterior cruciate ligament and posterior cruciate, they are going to be having some cross kind of structure, which we'll be discussing in our further lectures, right? Or further slide. Then we have our medial collateral ligament. So if you just look towards towards this knee, we have two aspects. We know we have the lateral aspect and medial aspect. You guys might be aware of these terminologies. Medial aspect is basically towards your central part, and lateral is away from your central part, right? So medial collateral ligament, here you are going to see medial collateral ligament, and here at that side you are going to see lateral collateral ligament, which we are going to discuss in a bit, okay? Then we have menisci. So what are menisci? These are basically a paired kind of structures which are present in between these bones. We know that the bones do not directly connect with the bones, right? So in the middle you have these, pads like structure. You guys can just see it here. These are going to be your menisci, right? Crescent shape, pad like structure, menisci, which we are going to discuss in our further slides, right? So this was about our bone. You guys can see this is your big femur, right? Your femur, you have your tibia, and you have your fibular bone, right? Okay, so remember, here you guys can see this is like, at the end of these bones, like almost, all type, if it's humerus, if it's femur, you have these bulges or outgrowth at the end, right? So these bulges are basically called as condyles. Okay, these big bulges are called as condyles, right? Okay, what is epicondyle? Epi mean above, right? So above these bulges, you are going to have these small bulges which are known as epicondyles, right? Epicondyle. So these terminologies should be kept in mind. What are the condyles? These are the end, the distal bulge-like structures which the bone form are condyle, and above that you have small bulges which are called as epicondyles, right? So you guys can see this was your femur. You can see your tibia, and that on the tibia, we discussed the tibial tuberosity upon which the ligament is attached. You guys know that, right? So we'll be discussing the significance of that tibial tuberosity in a pathology called as Osgood-Schlatter syndrome. Really important, really, and you might see an MCQ on your real exam as well from that topic, right? So tibial tuberosity is really important, right? So this is going to be your tibial tuberosity. You guys can see your fibula. This is your fibular bone, right? And this is your patellar bone, which is really important. As I already told you, it's going to be a connection between your upper leg and your lower leg, right? Okay. So let's just move to our next slide. Now let's discuss cruciate ligaments, right? Cruciate. As I just told you, what does the word cruciate mean? Cruciate means cross kind of structure, right? These cross, it's cruciate, right? So we have two ligaments, anterior cruciate ligament and posterior cruciate ligament. Let me just tell you the significance and the function of these ligaments. It's really important. You are going to have a lot of MCQs on your and it's really simple as well at the same time. For example, if this is your leg, right? Let's suppose this is your lower leg. Okay, I'm just drawing these structures really simple, right? So don't just ignore my drawing, okay? So this, let's suppose this is your big bone femur, and this is your, let's suppose tibia and fibula, right? So here you are going to be having anterior cruciate ligament. So anterior cruciate ligament is going to come from this posterior aspect of your femur, and is going to be joining at the anterior aspect of tibia, right? So you guys can see from this structure, you would know that what is the function of this structure, right? Okay, this is your foot, okay? Just like that, the person is lying, okay? So if I'm just taking this lower leg and I'm just moving it, upward towards the sky, Okay, so its motion is going to be limited by which ligament? By which ligament?
Posterior cruciate.
I'm just pulling it upward towards the sky. Patient is lying. Okay, this is an individual, he's lying. Okay, it's going to resist the anterior motion, towards up. He's lying. I'm just anteriorly moving it up towards the sky. That's, it would restrict the anterior motion of your lower leg. Due to this attachment, you guys can see if I'm just pulling it, this part of this ligament is going to hold. So in order to avoid the exaggerated movement of your lower leg, anterior cruciate ligament does that. It avoids the exaggerated, movement of your lower leg against the femur, So you can just think, what if my anterior cruciate ligament ruptured? What if it ruptured? So what would happen? Now you will be having exaggerated movement of your lower leg anteriorly. Am I right? Hello?
Yes.
Okay. So what would I just tell an individual?
Yes,
I just
yes.
tell it, okay, I'll just tell this individual to lay down. Okay. For example, if this is his foot, I'll just tell him to just make a 90-degree angle, just like that. This is your knee. Okay. And once I just pull it upward anteriorly, so I'll be having an exaggerated motion, which will just tell me that yes, I have, rupture of anterior cruciate ligament. Is it clear? Hello?
Yes.
Yes,
Okay.
doctor.
Do you guys
No.
know? Is it clear? Yes or
No.
no? No.
Not,
Okay.
no.
Okay. Let me just tell you. Okay. For example, this is an individual. He's laying down like that. Okay. This is his leg, his shin. Okay. And this is his thigh. Okay. And this is his knee joint. Is it clear now? Okay. Again, like this is the thigh of an individual. This is his shin, and this is the knee joint. Okay. So if I'm just pulling this leg upward, you have this ligament which won't let the leg to move upward anteriorly, right? Okay. If I just tell the same individual to lay down, make a 90-degree angle between your knee and your thigh and your shin, right? And if I'm just moving the leg upward, so this anterior cruciate ligament is going to restrict the movement of your lower leg against your femur. Is it clear now?
Yeah.
Okay. So what if this ligament get ruptured? What would happen? Now you can just move the thigh, here. Okay. And you can just move because there is no one to restrict this. Hello? Hello? Am I audible?
You're
Yes.
audible, but your voice
Your
is
voice is
disconnected.
breaking in between.
Okay, still it's breaking. I just connected my hello. Is it fine now? Hello?
Yes.
It is fine. In between, it is breaking.
Okay, let me just fix that, okay? Just give me a second, please. Hello?
Hello.
Hello?
Yes, doc.
Hello?
Yes, doctor. We can hear.
Am I audible now?
Yes.
Okay.
Yes, yes. we
Okay.
can.
That's great. Am I audible? So we were discussing about anterior cruciate ligament. It's going to restrict the movement of your lower leg, anteriorly. Right? That's basically the function of your
It's
anterior
even worse than earlier.
cruciate ligament.
Your voice
Is
is worse
it
than
clear now?
earlier.
Hello.
Ahmed, your voice is worse than ever.
Is even worse. It's 3 hours.
Okay. Well, let me just fix. Hello. Hello. It would be fine now. Hello.
Yes, doc.
Okay. Actually, I was just
Yes,
enjoying the
doctor.
weather outside, and I was just connected to my phone's internet. Okay. So thank you for bringing me back to my room. Okay. So we were discussing anterior cruciate ligament, right? So we discussed that anterior cruciate ligament is going to restrict the movement of your leg at knee joint. So if I'm just, pulling the leg upward, this motion is going to be restricted by your anterior cruciate ligament. And as we discussed, if we just steer this ligament, now we'll be having exaggerated motion of your lower leg against your femur. Am I right? Hello?
Yes.
Okay, so that's basically known as positive drawer test. Do you guys know what is drawer? Hello? We have a drawer, right? Like that. And we just put some clothes into that and we just push it in and pull it out, right? That's a drawer, right?
Yeah, yeah,
So
the
you guys
cupboard
can just
drawer.
imagine this. Yes, that's a drawer, right? So you guys can imagine the leg, this leg as a drawer, right? So if you are just exaggeratedly moving it upward, it would just get open like a drawer, right? Because we do not have anterior cruciate ligament to restrict its motion. So it's positive drawer test. You are just, pulling it openly like a drawer. Drawer can be open till, a big extent, right? So that's going to be a positive drawer test. Now let's discuss posterior cruciate ligament, right? So let me just draw the posterior cruciate ligament here. Okay. So as you guys know the function of anterior cruciate ligament, we are going to discuss that again. Don't worry, right? If you have any problem. So this is going to be your posterior cruciate ligament, just like that. Okay. It's going to be attached just like that. Okay. So what's the function of posterior cruciate ligament? Now, if I'm just moving leg, in this direction, so you guys can see due to this ligament, it would restrict the movement of leg, exaggerated movement of leg in posterior direction. Am I right? Hello?
Yes.
Okay.
Yes,
So
yes, doctor.
posterior cruciate ligament would restrict the motion of leg in posterior direction, and anterior cruciate ligament is going to restrict the movement of exaggerated movement of leg in anterior direction. Okay. So that's going to be the function of posterior cruciate ligament, which we'll be discussing in a while, right? So this was about the ligaments. Let's just discuss it, right? So we have two ligaments, anterior cruciate and posterior cruciate ligament, right? Okay, they have formed a cross. That's why we just call them cruciate ligaments, right? So what is the insertion and what is the origin of these ligaments? Let's discuss that. The anterior cruciate ligament comes from the lateral femoral condyle attached to anterior tibia. What is condyle? We discussed that big bulge. So we have medial condyle towards the central body and we have lateral condyle, right? So it would just come out of the posterior aspect of your lateral condyle and it would just get attached here, right? So it's coming from this lateral condyle and getting attached anteriorly to your tibia, right? It's the same picture which I have drawn, right? So it's coming from the lateral condyle and just attaching like that. So that's why it's going to restrict the exaggerated anterior motion of your leg. Is it clear? So it would resist the anterior movement of tibia, as I have already just, drawn a picture. You guys can see if I'm just moving, the leg like that. So this ligament is going to restrict the exaggerated movement. Is it clear? Hello?
Yes, yes,
Okay,
doctor. Yes.
perfect. Okay, what's the okay? Let's discuss posterior cruciate ligament. What's the origin? Okay, it's not necessary to know the origin and insertions of muscles, right? It's not necessary, but at least you should know the function of the muscles, tendons, and everything, right? So it would arise from the medial condyle and attach on posterior tibia, as I just told you, right? So from the medial condyle on the posterior tibia, just as I just draw the picture, you know. So this was your medial condyle, and it's just get attached to posterior tibia, right? So it means it would restrict the posterior movement of the leg at the knee joint, exaggerated movement. Okay, is it clear? Hello.
Yes,
Yes.
doc. Yes.
Okay. So whenever you are seeing these kind of picture, how would you know that what joint is it? You can first of all just look towards the patella, right? This is the patella bone, right? So it means it's the anterior aspect. So you guys can see these ligaments. This is your you. Okay, what ligament is this? You guys are going to be telling me that.
Anterior cruciate.
ACL.
That's
Yes.
anterior cruciate ligament, right? Coming here and
Yes.
okay. And what's this one?
PCL.
Posterior.
Okay.
Posterior.
So you can see they have formed a cross, right? So that's why we just call them cruciate ligaments. Is it clear?
Yes.
Okay, perfect. So you can see they have formed a cross, anterior and posterior cruciate ligament. That's all. Let's just come towards our. Okay, let's discuss some of important things, right? For example, if I have an individual, right? Okay, you guys are going to be telling me. Okay, for example, if he's just sitting in a car, right? Okay, and this is the dashboard of car. This is the car's dashboard, let's suppose. And an individual is just sitting like that. Okay, he will be sitting like that. Okay, on a seat. Am I right? Hello?
Yes, you
Yes,
are.
doctor.
Yes, doc.
Okay, perfect. Let's suppose if this car had an accident, right? So it means that the individual, these legs are going to strike the dashboard, right?
Yes.
Okay. It means that
Yes.
as they strike the dashboard, so the leg is going to move backward.
Yes.
Am I right?
Yes.
Against this knee joint. Against this knee joint. What do you think? Which ligament is going to be ruptured?
Posterior.
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 Yes.
Posterior
Perfect.
cruciate.
This is what.
Posterior. Yes.
Perfect. Perfect. So can I say that damage of posterior cruciate ligament is mostly seen in dashboard injuries?
That is correct.
Yes.
Okay,
Correct.
in U
Yes.
world, they are going
Yes.
to ask you the
Yes.
same MCQ. In the U world, they are going to ask you the same MCQ. An individual, he just had an accident, in a car. What do you think? Which ligament is going to be ruptured? That's a dashboard injury in which we are going to have posterior cruciate
Posterior
ligament injury. An
cruciate
individual,
ligament.
right? So that's so simple. Okay. So these are your cruciate ligaments. Let's discuss collateral ligaments. Okay. So as I already told you, these are going to be your collateral ligaments. We have two collateral ligaments, the medial and lateral, and that's so simple. The one ligament which is present at the medial aspects are called as medial collateral ligament, while present at the lateral are going to be your lateral collateral ligament. That's so simple, right? Okay. So sometimes we can have damage of these collateral ligaments as well. Really important. Okay. So here you are going to be having medial collateral ligament. Am I right? This is your medial collateral ligament. And this is going to be your lateral collateral ligament. Am I right? Okay. Let me just change the color. This is your medial collateral ligament. And here you have lateral collateral ligament. Am I right?
Yes. Yes.
How do I injure the medial collateral ligament? How do I injure that? If
A
someone
force
just
from
kick him,
the right side.
okay,
When someone kick him.
okay, if some, okay, let's suppose if he's just playing soccer and someone just kick him on the lateral aspect. So the middle is going to be ruptured. Am I right?
Yes.
Okay. So can I say
Transfer.
in contact sports, we are going to be having mostly injury of medial collateral ligament if someone just strike it with them from the lateral aspect. Am I right?
Yes.
Yes.
Yes. Yes. Mhm.
Okay. 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 How the lateral ligament is going to be damaged? It's going to be damaged if someone just kick him from the medial side, right? But that's really rare to have a kick from medial side. Am I right?
Major side. No.
Yes. Yes. Yes.
It's
Yes.
really rare. How can one just get kicked from medial side? That's really rare, right? Okay. So it means that rupture of medial collateral ligament is common, while rupture of your lateral collateral ligament, yes, in UFC we can have that. Okay. And lateral collateral ligament is, you know, rare, but we can have in UFC, as just doctor just told us, right? We can have that. Okay. So if the medial is ruptured, the leg is going to be knocked. We are going to be having knee knock, and this leg is going to move at the lateral side. We know that that makes sense if this part just get ruptured. So we are going to be having, okay, an inverted V is going to be formed between his legs, right? Inverted V. So this movement is called as valgus movement. Okay, this is valgus.
Movement.
Okay, inverted V is valgus, right? Okay. So let's suppose if we have damage to the lateral ligament, it means now the individual is going to be having legs like that. Okay. Let me just draw the shape. It's going to be like that. Okay. If the lateral one get damaged, am I right? If just someone strike it from the middle part, the medial side, this ligament get ruptured. So we are going to be having somewhat structures like that. The knee is going to be moving. That's not going to be a knock knee. We are going to be having structure like that. Am I right? Hello.
Yes.
You're right.
Okay, so you can see we have a straight V being formed in the legs, which is going to be varus, right? Varus or board leg. You can see it's board leg. The leg is going to be adducted, okay, towards, and here the leg was abducted. What do we mean by adducted? You are adding adding. You are adding the foot to your body. That's adduction, and abduction is opposite. You are removing the foot apart from your body. That is abduction. So here you can see it's moving apart from your central portion. So it's abduction, and once we are just moving like towards the central portion of your body, that is adduction. Am I right? Hello. Okay. Then we have
Yes.
middle collateral ligament. We discussed that it would resist the valgus stress. It would resist the valgus stress. We know that. Okay. Okay, so it basically arises from the medial epicondyle and medial condyle of tibia. Medial epicondyle is a small bulge above the condyle. Here, a small bulge inserting on the medial condyle. The tibia itself has bulges. Whenever we have bulges in a bone, we call them condyles, right? If it's epicondyle, it means a small bulge above the condyle. Is it clear? Hello?
Yes.
Okay. So let's discuss lateral collateral ligament. In this lateral collateral ligament, you guys can see that it basically starts from the lateral aspect, and the head of fibula is inserted here, and it's going to resist the varus stress. As we know that, we discussed the valgus and varus, right? Let's discuss menisci. As I just told you, what are menisci? The menisci were basically those crescent shaped structures, pads, which were present between the bones. Here you guys can see these are the menisci. Okay, so we have two menisci, the medial and the lateral. The medial, which lies to the medial aspect, the lateral lies to the lateral aspect. That's so simple, right? So they are basically fibrous tissue and cartilaginous structures. Those are called as menisci. Okay, knee injury. Okay, whenever anyone is having a knee injury, so there are going to be certain obvious signs and features which are going to be present. What's that? We are going to be having swelling. We are going to be having instability, because it's the only joint which is leading to redistribution of weight to your lower leg. So if we do not have that redistribution, so an individual cannot stand upright, it's going to be really hard for him to redistribute his weight if whenever we have any rupture or whenever we have any damage to the knee, right? So an individual is going to be having a sensation like his knee is just falling out. Okay, so he's going to be saying that I think my leg is just falling, right? Okay, so ACL injury, anterior cruciate ligament. We discussed the function of anterior cruciate ligament. What was the function of anterior cruciate ligament? Avoid exaggerated
Anterior movement.
anterior motion of your lower leg. I'm just writing in a simple English, right? Of your lower leg, at knee joint against your big femur, right? So mostly in contact sport, ACL is the most common which get injured. You might have, listened it a lot, right? In soccers and footballers, ACL is really common in them, right? Okay, so most commonly injured, often a non-contact athletic injury, right? In contact, we can have that, but in the soccer, why do we have anterior cruciate ligament injury? The thing is, whenever an individual is jumping, whenever he's running, like he's moving forward, so anterior cruciate ligament can have a lot of, stress on it. And as it get tear, individual is going to hear that plop like sound or pop like sound. Yes, it's tear. He is going to experience that sound. Okay. And it can also be injured when an individual is just standing on his leg and suddenly he's changing the direction, right? Suddenly, what do I mean by that? Like if an individual is just standing, it's his knee joint, and suddenly he's just changing his his direction. So what happens? You are basically rotating your knee, right, at the knee joint, rotation. So it can also rupture your anterior cruciate ligament. Okay. So okay, as we discussed that whenever we are suspecting of ACL injury, where we do a test called as anterior or drawer test, right? So you are going to tell an individual to lay down, make a 90-degree angle in between his knee, and then if you just pull this leg, it's going to be having exaggerated forward movement, which is going to tell you that we have positive anterior drawer sign, right? Leishman test. What is Leishman test? Here we just made a 90-degree angle, just make a 30-degree angle and just pull it outward. And if you have exaggerated motion, that's going to be your injury of your ACL. That's simple. Posterior cruciate ligament, right? We discussed that posterior cruciate ligament is going to avoid the exaggerated movement of your leg backward, posteriorly, right? And we discussed in dashboard injury, it's going to be the most common ligament which get ruptured, right? So for that, we have to do a posterior drawer test instead of just pulling out the drawer, just pull in the drawer, right? In posterior direction. So it's going to, if we have exaggerated movement, it's going to confirm that we have posterior cruciate ligament rupture. Is it clear? Hello? Hello? Okay.
Yes.
Perfect.
Yes.
Okay. So we discussed the medial collateral ligament injury. We know that the medial collateral ligament is going to be present. Okay, just give me a second. Let me just erase it first. Okay. So as I already told you, the medial collateral ligament is going to be present here. When do we get it injured? For in a context, what if someone just had hit you from the lateral aspect, and we are going to be having this valgus deformity. In inverted V is valgus, and straight V is your varus deformity, right? So you guys can just read it from the lateral side. Lower leg is going to be abducted, and we have a medial space, a big space in between. Okay, so we already discussed that. We are only going to read this slides. We have something called unhappy triad. What is unhappy triad? In this case, an individual is going to become really unhappy, right? He's going to be unhappy. And what's the reason of that? Because he is going to have tear of a lot of things in his leg. If he have tear of a single thing, he won't be that unhappy. But if I just tear three things in his knee joint, obviously he's going to be really unhappy, right? Just kidding. Okay, so unhappy triad. What is unhappy triad? Whenever we have ruptured of three things: anterior cruciate ligament, medial collateral ligament, and medial menisci. AMM. Anterior cruciate, medial collateral, and medial menisci. Whenever three of them are injured, we just call them as unhappy triad. Mostly it's going to be seen in contact sports, right? Contact sports, we are going to see this unhappy triad. So you guys can see it here that we have the medial is basically ruptured, the medial menisci is gone, and the ACL is gone. That's simply called as unhappy triad. I don't know why they just call it unhappy triad. Okay, so lateral collateral ligament. We discussed lateral collateral ligament is going to be present on the lateral aspect. Okay, and it's really rare to injure it in isolation. Like as I already told you, it's really rare to have injury from the medial side instead of UFC fighters, as Dr. Ishton just told us. Okay, so often the trauma to medial knee, and as we have that, we're going to be have abnormal passive adduction, as I already told you, right? That's going to be varus deformity. Am I right? Hello? Hello?
Yes, sir.
Yes.
Yes.
Okay. Okay, perfect. Then let's discuss our meniscal tear, right? So we discussed we have the two pads kind of structures which are present called as menisci, made up of cartilages. So how do we rupture those menisci? It's really easy to rupture them, by the way. Okay, Again, if someone is just standing, you know, and again he just turned his position, or he's just rotating his femur and the knee joint, again these menisci are going to be tear. Just think of this condition: individual standing, and suddenly he just changes his direction, and he just externally or internally rotated his femur along that knee joint. There is going to be a lot of pressure on those menisci, right? And those menisci can be ruptured, right? So whenever we have rupture or tear of those menisci, oftenly it's going to be seen when the foot is planted. Sudden change in direction. We know that we're in like basketball or soccer players. So we're going to be having a lot of pain, swelling after the injury. That's really common, and the pain would worse while twisting or pivoting. If further you are just twisting, so it's going to worsen the pain because it was due to internally or externally rotating your your femur along the knee joint. Okay, so we have a test that is now called as McMurray test, right? What is McMurray test? It's used to diagnose whether your medial pad is damaged, or your lateral menisci, medial or lateral menisci is damaged. So in this test, what we do, we just tell an individual to lay down flat again, right? So we are going to tell an individual to lay down. Again, we are going to make that 90-degree angle, and as we just make that 90-degree angle, we are going to hold his foot. Either we are going to externally rotate it or internally rotate it, right? Do you know what is external or internal rotation? Clockwise or anti-clockwise rotation, okay? Hello?
Yes. Yes.
Okay. So there is a mnemonic called Lyme, okay? If on internal rotation, an individual experience a lot of pain, it means your lateral menisci is gone, right? On external rotation, and if an individual just experience pain, it means your medial menisci is gone. Is it clear? So if I just rotate the leg internally, he's experiencing pain or any sound, a pop-like sound. I'm going to, and you can just close your eyes. You can just imagine if I'm internally rotating, so it means that the lateral is going to, if the lateral is affected, that's going to cause pain or pop-like sound. If I'm externally rotated, it means the medial is, problem with the medial or tear of medial menisci. Is it clear? That's called your McMurray test. So you're going to tell the individual to lay supine, flex his knee, knees flex, hold the foot with the hand, externally or internally rotate. If on internal rotation an individual is experiencing pain, it's a positive McMurray. It means you have lateral damage, right? And if external rotation an individual is experiencing pain or pop-like sound, it's going to be your medial meniscum. Is it clear? Hello?
Yes.
Okay, perfect. Okay, so let's just discuss now our knee joint, right? So, okay, knee joint. Okay, so it's basically a synovial joint. We are going to discuss different types of joints in our further lectures. But you know what is synovial joint? It's going to have a synovial fluid, right? A synovial fluid, a synovial membrane. This is basically a synovium, which basically excrete this fluid. We are going to be discussing that in pathologies. If we have inflammation of synovium, we are going to be having which pathology. But at least you should know what is synovium. Okay, so this part is basically going to be, you have a layer that's called as synovium. So the knee is basically a synovial joint. We have a lot of fluid here in order to avoid the friction between the bones. That's a synovial fluid. And what's the function of joints? Joints basically connect bones. We know that. Okay. So what's bursa? Do you guys know what is bursa? Hello.
This like pad around the joint.
And it's a shock
Friction
Okay,
pad.
absorber for
it's
the
a
Shock
joints.
absorber.
Shock absorber,
yes,
I
it's
think.
a
No part.
it's a
That is
shock absorber.
synovial.
What else? It's basically a synovial line or a big, you can just imagine it's a, a rubber pad kind of structure, a rubber pad, right? That's best thing which we can just, say, a rubber pad, right? So it's a rubber kind of structure, which is basically going to be present between the muscles, tendons and muscles. And what would be the function of them? The function is to avoid friction, absorb shocks. If an individual just have a, okay, if this is a knee joint and we have patella, So in front of patella, we have this bursa, which is known as pre-patellar bursa, right? That's what's going to be the significance of that. First of all, it's going to avoid friction between different muscles, different tendons, and other, it's going to be shock absorber. If someone is having hit, if someone just fall on the knees, it's going to absorb that shock, the rubber pad absorbing the shock. Sometimes these bursas can also get inflamed, which is called as bursitis, right? Bursitis, inflammation of bursa is bursitis. So as I already told you, we have a lot of bursa, like not only in the knee joint, we have bursa in the elbow joint, a lot of places in the ankle, we still have a bursa, right? So, everywhere it's really important, right? It's really important in all of those places in order to act as a shock absorber or in order to avoid, friction between the muscle tendons, right? So, pre-patellar bursitis, pre-patellar, in front of patellar bone, we have a bursa. Pre-patellar bursitis, if that bursa get inflamed, we are going to call it as pre-patellar bursitis. And how do we have inflammation of that pre-patellar? It's not direct due to some certain, bugs growing on there. It's due to overuse. It's due to overuse. So if an individual is, repeatedly kneeling, for example, the housemates, they keep on repeatedly kneeling in order to clean things, right? So repeated kneeling is going to lead to pre-patellar bursitis. Really important, right? Okay, other causes can be infection. Infection itself can cause bursitis, but mostly it's going to be seen in nursemaid. That's why it's also known as nursemaid. It's really important, one of your UWorld MCQ as well, right? So it can be due to infection, due to gout, which we are going to discuss if the sodium monourate crystal just deposit there leads to inflammation. So we are going to discuss that in our pathology section. So an individual with pre-patellar bursitis is basically going to experience pain with activity, and that makes sense. If we have inflammation there, and you're again just using your knee joint, it's going to cause a lot of pain due to inflammation going on there, right? So we are having inflammation. Obviously, we are going to be having warmth there because inflammatory cells are going to come there sometimes, right? And when the blood vessels are going to be dilated, giving you that warm sensation there, and we are going to be having exactly swelling there, right? Because due to inflammation, we can have edema, it can just swell up, right? So these are some common features of inflammation which you guys know well, right? The next topic which we are going to discuss is Baker's cyst. Baker's cyst. What is Baker's cyst? Sometimes you can have, okay, this is your popliteal fossa, right? This is your popliteal fossa. Am I right? Popliteus. Am I right? Hello.
Yes.
Yes, sir.
Yes,
Okay.
yes.
So this area is basically your popliteal fossa. Sometimes you can have a big cyst here, okay? A big cyst here. And that cyst is going to be, it would be having, fluid inside it. But it can cause a lot of problem, which we'll be discussing in our next section, right? So if you guys remember, we have a nerve called as a sciatic nerve. Do you guys remember the sciatic, the largest nerve, 2 centimeter wide? Okay.
Yes.
Yes. And the
Yes,
frequency is
yes.
Okay.
high.
So the sciatic nerve basically just come back. It just supplies the hamstring muscles. And here at the level of tibia, it basically divided into two branches, the common peroneal branches and the tibial branch, right? Coming like that. So this Baker cyst is basically going to disrupt the tibial branch of your sciatic nerve. It's really important. What's the function of this tibial? It's really important. It's going to supply the posterior compartment of leg. It would be just coming here and it would lead to plantar flexion. Do you know what is plantar flexion? If this is your leg, moving it up towards the sky is dorsiflexion, and moving it down like that is your plantar flexion, right? So this tibial nerve is basically really important in plantar flexion of your leg, which we are going to discuss in our lower limb, right? So this Baker cyst can disrupt which nerve? Really important. Your
Tibial. Tibial.
tibial nerve. Okay. Okay. So sometimes this big cyst can, lead to a lot of painful situation as well. Like it can cause a lot of pain here, right? If it's growing in size, it can cause a lot of pain. And if you guys remember, we were having a condition called DVT. In DVT, we were also having a sudden pain, right? And the most common places where we can have DVT is the popliteal vein, somewhere here, right? Right? In the popliteal vein, right? So if you have pain, we have a severe pain in DVT as well and pain in Baker cyst as well, right? So sometimes this Baker cyst can be misunderstood as DVT because in DVT, popliteal vein can have a thrombus, deep vein thrombus, right? That's a deep vein. and the Baker cyst itself can cause a lot of pain. So sometimes the Baker cyst is going to be misunderstood. Most of the time, it's going to be asymptomatic, right? But if it grow in size, it become inflamed by any of the condition, it can lead to a lot of pain, which can be misunderstood as a DVT. Keep that in mind, right? So we have gastrocnemius and semimembranous bursa, right? So this is your gastrocnemius and your semimembranous. You have a bursa here, right? Okay, between these muscles, it can lead to a lot of fluid accumulation, which is called as Baker cyst. It can often communicate with synovial space. Like sometimes it can communicate with that joint as well, right? Like often it can be related to degenerative diseases, which we'll be discussing in detail, inflammatory and joint injuries as well, right? But a really important thing, two things which you should just keep in mind, it can mimic DVT. It can mimic DVT due to pain, and it's going to affect the tibial nerve. It isn't written here, but keep that in mind. Tibial nerve is going to be, like disrupted if you have a big Baker cyst here, right? So if often leads to really small asymptomatic, but if it's grow in size, it can cause pain. It can disrupt the nerve as well, right? That is going to be your tibial nerve, right? Okay, so you guys can see this is your Baker cyst. They have given you a picture of that. Okay, this is your patella. So this is going to be your popliteal fossa, and you have this big cyst, which is Baker cyst, which is often diagnosed, accidentally on X-rays. Okay, so mhm. Okay. So the next disease which we are going to discuss is Osgood-Schlatter disease. As I just told you, really important tibial tuberosity. Do you guys remember that? I just told you. Okay, so here we were discussing that this big tendon of your muscles basically crosses your patella and it get inserted into your tibia here on your tibial tuberosity. You guys remember that? Hello?
Yes.
Yes.
Okay. Remember, this part of your tibia basically, undergoes something called a secondary ossification. Okay, it undergoes something called secondary ossification. Or another thing, let me just make it really simple. You can just think that this part of tibia is really weak. This tuberosity of tibia is really weak, right? So if I'm just having, if I'm just overusing this, anterior thigh muscles, so as it have been inserted on a really weak portion of tibia, so sometimes this tibial tuberosity can break and shatter into pieces. That's simple, right? It's really weak. If I'm just overusing this muscle again and again, again and again, so this tibia or tibial tuberosity can have a fracture, and you can just detach this insertion, right? Okay, so mostly it's going to be seen in children. Okay, and it's usually benign, it's self-limited, and basically whenever a children is overusing his muscle, this big muscle, anterior thigh muscle, so it can sometimes shatter this tibial tuberosity due to secondary ossification. It's really weak structure. That's called Osgood-Schlatter disease. That's so simple, right? I don't know why have they given it so so hard name, Osgood-Schlatter. No, that's so simple. Whenever we are a child basically is overusing his anterior thigh muscles, it can lead to damage or small fractures, you can say, or shattering, Schlatter, right? Shattering of that tubular tuberosity, which is called as Osgood-Schlatter syndrome or disease. Okay, is it clear? Hello.
Yes.
Okay,
Yes.
perfect. Perfect. The next one which we are going to discuss is patellar fracture. As I just told you, what is patella? Patella is that small triangular kind of bone which is present in front of your knee. And I have just told you the significance of patella, the patella bone. It's really important because it's the only medium or the only bone which, connects your upper leg with your lower leg, right? So if you have damage or, fracture of this patella, it means now we cannot redistribute, the weight from your upper leg into the lower leg. Am I right? The communication between upper and lower leg is lost. Can I say that? Making it simple, right?
Yes, sir.
Okay, so for extension or standing, if an individual is standing, he uses his extensor, right? He uses his extensor muscles, right? So if an individual is standing, he's using his extensors. It means he have to redistribute his weight on his lower legs, right? And as we do not have patella there, so can we redistribute the weight to the lower legs? No. So it means an individual could not stand against the gravity. Am I right? Hello? Hello?
Yes.
Yes.
Yes,
Okay,
yes.
perfect. So as we discussed, we have whenever we have patellar fracture, it results from trauma. You are going to be having swollen, painful knee. That's quite simple. So you guys can see it's a full fracture of your patella. Now you cannot redistribute the upper body weight to the lower body weight. So individual cannot stand for the standing. I have to redistribute my weight, upon my lower legs in order to stand, right? So it would, a loss of knee extension. You cannot extend the knee, right? Okay, so you can see this was basically your quadricep tendon, right? So we have these four muscles which we'll be discussing. The anterior thigh, which I was just referring to, anterior thigh muscles, that are quadricep muscle. Okay, and their tendons just move upon this patella to get inserted into to your tibial tuberosity, which is really weak, and with overuse you can shatter that, called as Osgood-Schlatter syndrome or disease, right? Okay, so the diagnosis is going to be made via X-ray. Okay, so injury to the patellar tendon can be ruptured. You have patellar tendon as well, and you have quadricep tendon which is passing upon your patella. So both of them can get ruptured. Okay, due to any kind of injury. Is it clear? So let's have a quick review of whatever we learned, and then we are going to move forward. Is it fine? Hello.
Yes, doctor.
Okay, so we did a lot of things. Knee is made up of four joints, four bones. You have a big bone, two small bone, a femur, tibia, fibula. We have ligaments, anterior cruciate ligament, posterior cruciate ligament, medial collateral, lateral collateral. Just close your eyes and just listen whatever I am saying, okay? And just think whether you remembered or not, right? So close your eyes and think whatever I'm saying, okay? Just imagine. Okay, so we have four ligaments: anterior cruciate, posterior cruciate, medial cruciate, and no, not cruciate, collateral, and lateral collateral, right? We have two menisci, medial and lateral. We know that. We have condyles, the big bulges. Upon those big bulges, we have small bulges called epicondyles. Okay. Cruciate. Why do we call them cruciate? Because they make a cross. Okay. Okay, we discussed that anterior cruciate ligament is going to be resisting the exaggerated anterior motion of your lower leg against your in your knee joint against your femur, right? Posterior is going to resist the posterior cruciate, the exaggerated movement of exaggerated posterior movement of your leg. We know that in dashboard injury, that's going to be the most common one, getting ruptured, right? Okay. Drawer test, anterior drawer test for injury of anterior cruciate ligament, posterior drawer test for posterior cruciate ligament. We know that. Valgus and varus deformities. If you just get hit from the lateral aspect, medial is going to be damaged. You are going to be having knock knee, abducted leg. That's a which deformity? Valgus deformity, right? Okay. And if you have from the medial in UFC medial side, someone just hit you, you can have damage to the lateral collateral ligament. We can have a straight V, that is a varus deformity, right? Okay. Collateral ligaments, we discussed that. Menisci, we have two menisci, medial and lateral. Okay. We do a McMurray test for that. External rotation is going to give you pain. Which menisci is damaged? Yes, please.
Medial.
External rotation, medial, right? And internal rotation, lateral.
Lateral.
PCL dashboard injury, we discussed this. Unhappy triad, an individual is really unhappy because he have AMM injury, anterior cruciate ligament. He have medial, a meniscal tear, and he have medial collateral damage. Okay. Okay, lateral, we discussed that. Meniscal tear, we discussed McMurray test, we discussed knee joint, bursa, we know that fair pad-like structure which, resist the, avoid the resistance, the friction, shock absorber, pre-patellar bursitis, house-made, kneeling again and again, inflammation of pre-patellar bursa, one of your U-World MCQ. Baker cyst, big cyst in the popliteal can mimic DVT. Tibial nerve is going to be impacted. Mostly it's going to be small, asymptomatic. And whenever we have an accidental finding, we can just see that. Baker cyst, we discuss Osgood Schlatter, something is shattering. What is shattering? The tibial tuberosity. Because it's very weak, and a child always just runs. He play games, so he's going to be overusing that. And since he's a child, already the bones are weak and the tibial tuberosity is further weak. We know that. So we can shatter that. That's Osgood Schlatter disease. Okay. Patellar fracture, no redistribution of weight, and individual cannot stand. We can have two rupture of two ligaments here, right? Or tendons here. That's going to be quadricep tendon and patellar. Okay, that was all. Is it clear? Now, let's discuss our shoulder and elbow.
Yes, thank you.
Okay. Okay. Shoulder and elbow joints. Okay. We know that shoulder is made up of scapula, right? This is the scapula. Scapula basically is having that small concave kind of structure in which we insert, your humerus, right? This fossa is known as what movements lead to tibial? Sorry. Okay. So this is basically known as glenoid fossa. Glenoid fossa. Is it clear? Glenoid fossa. And this is going to be your humerus and the humerus head, right? So the shoulder is going to be a ball and socket joint. In a ball of socket and socket joint, we can have a lot of range of movement. Like we can have flexion, we can have extension, we can have abduction, we can have adduction, we can have internal rotation, we can have external rotation. All of them can be seen in ball and socket or a variety of movement, right? So glenoid fossa, which is basically, present in the scapula. Three bones are present in the shoulder. Scapula, humerus, and this tiny bone, don't forget it, clavicle, right? Clavicle bone. Okay. So these are the movements which we can see your flexion, extension, abduction, adduction, and rotation. Okay. Okay, rotator cuff muscles. What are your rotator cuff muscles? Basically, on the shoulder, you have a group of muscles called rotator cuff muscles. And what are the function of those rotator cuff muscles? Those rotator cuff muscles are basically going to hold your humerus in that glenoid fossa. You have glenoid fossa. In order to hold this humerus into the fossa, we need some external force, which is given by these group of muscles called rotator cuff muscles. Is it clear? Hello? Okay. So we have four muscles. The mnemonic for that is SITS. Okay. We have supraspinatus. I'm going to tell you why we call it supraspinatus, right? We have supraspinatus. We have infraspinatus. We have teres minor, and we have subscapularis. Okay. So these are going to be the four muscles in your rotator cuff. What's the function of them? The function of them is to hold the humerus head in the glenoid fossa, right? During abduction. If I'm abducting it, my arm, I'm just moving it away from my body. Still, the glenoid fossa and your humerus the head of humerus do not leave the glenoid fossa. It's going to be held there by these group of muscles, as I already told you, right? So tendinitis, sometimes you can have, inflammation of the tendons, which is going to cause, pain while abduction. We are going to discuss that, right? Or unstable abduction if you do not have any of the muscles in your rotator cuff are having any problem. So the first muscle is supraspinatus. Why do we call it as supraspinatus? So you guys can see it here. You have this scapula, right? This is your entire scapula. Am I right? This is your scapula, right? Hello? Hello?
Yes.
The scapula itself have a spine. As we are having a spine, right? All of us, we have spine, right? So basically there is an outgrowth on scapula which is called the spine of scapula. Spine of scapula. So this muscle is going to be present above that spine. That's why I just call it as supraspinatus. That's so simple, right? Okay. This is your spine process, you can see. So it's going to be present here. So as you can see, this muscle is going to arise from here and it's going to insert somewhere here on your humerus, right? It's going to insert here on your humerus. Am I right? Hello?
Yes.
Okay.
Yes.
Yes.
Okay. So if I'm just pulling this muscle from here, if I'm just pulling it, what would I just do to the arm? Won't the arm move upward? Like,
Yes.
won't the arm be abducted?
Abduction.
Moving upward. That's abduction, right? So you can simply imagine if I'm just okay. So whenever I'm just pulling this muscle from the from this side, the origin side. This is the origin of muscle. This is the insertion of muscle attached here. So if I'm just pulling this muscle, the arm is going to be abducted. Am I right? So what's the function of this muscle? This muscle is going to abduct your arm, but only till 115 degree, right? Only till 15 degree. Above the 15 degree to 90 degree, your deltoid muscle do that. Your deltoid does that after 15 degree till 90 degree. Is it clear? So initial 15 degree of abduction is done by your supraspinatus. Okay. Who innervate the supraspinatus? Suprascapular. Supraspinatus for suprascapular. Scapula, suprascapular, right? It's some, suprascapular. It means this muscle nerve is going to be here. Supra, above the scapula. Above the scapula, you have supraspinatus muscle. So this is going to be innervated by suprascapular nerve. Am I right? It's the most common one which get injured in your rotator cuff. And what's the reason behind that? We'll be discussing that. Okay. The reason is mentioned here. You can see this is basically your supraspinatus. It's coming like that and it's inserted here onto your humerus. So you can see you have this process of your scapula which is known as, yes, acromion process, right? So if I'm just moving, abducting this arm, so you can see this space becomes very less between the acromion process and head of humerus. Am I right? The space become really less if I'm just abducting it again and again. So sometime due to less space, the tendon of this muscle can get impinged. Due to impingement, I'm trapping it between that less space while I'm abducting my arm between the acromion process and between the head of your humerus. That's so simple. So this is your acromion process. You can see right here the acromion process is drawn here, right? So if I'm abducting my arm again and again, again and again, which tendon is going to be tendon of which muscle is going to be impinged? That's your supraspinatus. So that's why
Spinatus.
supraspinatus is going to be the most common one, which is going to get involved in rotator cuff injury or any problem, right? So you can see supraspinatus. Okay, so I think we have made this muscle quite easy. Supraspinatus above the spine. Okay, and we know that. Okay, just give me this. Okay. I don't know what's happening to my. Okay. Okay. So as we discussed that we have this supraspinatus. Okay. So we can have. Okay, just give me a second. Let me just open it again. Okay. So as we discussed, supraspinatus, the function of it is initial 15-degree abduction. It's going to be impinged. Why? Because in swimmers and overthrowers, they're basically, abducting their arm a lot, So they can, the tendon can get impinged between the acromion process and head of femur. It's really important. You'll be having a UWorld MCQ related to supraspinatus and impingement. Is it clear?
Yes.
Hello? Okay. So there is a test called empty cane test and a full cane test, which is going to tell you whether your supraspinatus is affected or injured or not, right? So what is empty cane test and what is full cane test? Let's just discuss that. Okay. There is some problem with my pencil. I don't know why isn't it. Okay. I was just doing. Okay. So we have something called empty cane test and a full cane test, right? So we are going to tell, for example, if this is an individual, we are going to tell him to stretch his arm outward like that, 90-degree, right? Or 30-degree in front. Okay. And we are going to tell him to give me a thumb up, right? So if he's giving me a thumb up, it means his thumb is going towards the sky, right? Okay. Or if I just tell him to hold a cane, You know, if he's just holding a cane, it means he's having a full cane, right? Okay. But if I'm just giving him to give me a thumb down, so it means now the cane, he's going to invert the cane. That's going to be an empty cane, because as he's just giving me a thumb down, the cane is going to get empty. It's going to spill. Am I right? Cola wasted, yes. So that's basically an empty cane test and a full cane test. So if I just tell this individual to just give me a thumb up, okay, I can just call it a thumb up test as well, right? That's my own test. Thumb up or thumb down test, right? Just forget about the empty, full, empty, and Okay, so thumb up test. And I'm going to tell this individual to keep on moving his thumb up, and I'm going to resist the motion, right? I'm going to move his hand down. He is going to give me thumb up. If he experience any kind of pain, it means he have injury to supraspinatus. That's so simple, right? And if I just telling this individual to give me a thumb down, so then I'll be applying force upward. He's going to apply force downward. Still, if he is having pain, it means your supraspinatus muscle is injured. So this was my test, thumb up and thumb down. What does the BNB says, or your first set? That's an empty cane. You're going to tell this individual to hold a full cane, and then you're going to apply the force downward. If he's experiencing any pain, that's going to be a full cane test, right? Then you're going to tell him an empty cane, then the force now is going to be in the opposite direction. So in either direction, if he's just experiencing any pain, it means we have injury or damage to the supraspinatus muscle. Is it cleared? Yes or no? Hello?
Very
Yes.
clear.
Yes.
Okay. Okay, so this was all about today's lecture. As the time is finished, I have already shared the schedule. Did you guys enjoy the session? Hello?
Yes. Yes.
Yes.
A lot.
Yes.
Yes, a lot.
Perf- Perfect. So we are going to finish this this off in tomorrow, day after tomorrow, right? This anatomy at least, right? And then we are going to continue again. We are going to do the pathology from pathoma first, and in bootcamp session, I'll be revising the entire first aid. That's going to be our pattern from now onwards. Okay. Okay. Thank you so much. Thank you, and I have just shared the schedule. You guys can just practice your MCQs.
Question, did we get the recording from Tuesday?
From Tuesday. Okay, I'll just see the recordings. I think I have just sent them. If not, so I'll just upload them. Okay.
Okay, yeah, the one from Tuesday.
Sure. I'll just send it. Okay. Thank you so much. If you have any doubt, just please, we have created this group, and if you have any problems with any MCQ, anything, just share it in the group, and I'm there like 24/7, right? And Dr. Muaz is also there, and Dr. Hassan is also there. So if you have any kind of problem after the lecture, so we are going to either send you a voice note, we're going to send you some notes if you guys have any questions. So just ask there, and thank you so much, and see you tomorrow. Thank you. Have a nice day. Bye-bye.
Bye-bye.